Good evening, everyone. How are you all? Great. So, welcome to First Aid AMC MCQ free 2-week sessions again. So, this is going to be your one of the last two session out of these free 2 weeks classes, and I hope that you guys are enjoying it so far. So, this is about cardiology question solve. We finished most of the cardiology topic in our last two classes. But again, we couldn't finish the palpitation chapter, and also we didn't do the ECG yet, which will be covered in our course, and our course student is going to get that. So once we finish this free session, we will finish that ECG class and do the palpitation cluster as well. Okay? So the cardiology question solve is based on the theory knowledge that you guys have. Now, I understand that if you don't get it right, but you can definitely try to answer based on the knowledge, based on what we have discussed so far. Many of the questions you should be able to get it right. I also, in this class, we also added some ECG questions and also some palpitation related questions, which I understand you will not get it, which is fine. But given this is a cardiac question solve, there is like it's impossible to take a cardiac question solve without ECG or without palpitation topic. So I have added few of those topics so that you get an idea as well. Okay. So let's start the class. Now, if you guys have any questions about the topics that we're discussing, about the questions that I'm discussing, feel free to just ask it in the chat box. I'll be more than happy to answer any of your queries. Yes, so these question solve sessions are based on previous questions that's common for exam. Today's class will be uploaded in the YouTube just like any other free classes. There is a deadline for the second half of the payment, which will be 6 weeks from we started the course, which was 6th of January. So from 6th of January, 6 weeks, you will have the time to pay the second installment. There is no last day to enroll the course. You can enroll at any time, but I always advise that if you are going to do the course, make sure you don't miss out. Make sure there is no gap. It's always the best if you can just follow what we are doing. Because when I make the classes, I do this way so that it makes sense to you so that suddenly I don't start discussing something really difficult. I want to go slow. I want to make sure you guys get comfortable, and then I gradually make it hard. Okay, so that you don't feel really stressed. So out of nowhere, if anyone join in the middle of the course, that's the time you get into the problem. It looks too much, you become overwhelming. So if you can, and if you're already here, I would definitely suggest to get enrolled so that you don't miss out or you don't end up joining the course in the middle. Okay. Now, yesterday, our software or the student portal went through a maintenance because we wanted to have there were some bugs that we wanted to clear, and we also wanted to make some changes in the software. So there was a bit of maintenance time, about 10 to 12 hours. Now the software is fine again, it's up and running. Anyone who had a bit difficulty yesterday, there should not be any trouble today at all. Why can't access for payment, K? What happened if you are trying to make the payment? It's very nice and easy. A lot of people has done it, and we have like hundreds of students who make payment online. There is no issue unless your your card does not allow online transaction, then there will be an issue. And what about who already paid for the course, Prakash? What do you mean? So long-term therapy, especially for angina or MI patient, long-term therapy will be continued forever, except the dual antiplatelet, which is the clopidogrel, that usually gets stopped within 6 to 12 months if a patient is on a stent. Apart from the dual antiplatelet, everything else like beta blocker, ACE inhibitor, statin, all of them will be continued forever. And Manish, why you would need multiple device access for a single class on Zoom? Okay, I'll come into these questions about the portal or enrollment just after tonight's session. Okay, so let's go on and let's finish what we wanted to do today first, and after that we will come into that. So starting with our first question today. So all of the questions that I have taken, it is exam oriented questions, the question that frequently appear in exam, not exactly the question, but the similar pattern of questions that you'll get into the exam. Okay. So always I mention that when you are doing a question solve, the idea is you get to understand the question, you get to understand the topic fully, and know each and everything about that topic. There will be nothing unturned about a topic that frequently comes in exam. Okay, you need to know each and everything about that. So that's how you should prepare. Like this is our first question. A 72-year-old woman presents with progressive shortness of breath on exertion and also orthopnea. So it's a 72-year-old progressive shortness of breath on exertion. So we have got SOB on exertion. We have got orthopnea in this patient. On examination, she has bibasal crepitation, bilateral ankle edema, and a systolic murmur based hard at the cardiac apex. Her pulse is irregularly irregular. Blood pressure is stable. What is the most likely diagnosis? So exam questions are usually full questions. When you do recalls, when you do past questions, you will never get a full question. So sometimes to give you an idea about how exam question is going to be, we try to make it a full question. Okay? But the main part of the question remains the same. So have a look over here. They're asking about the diagnosis. We have got options of aortic stenosis, mitral regurgitation, tricuspid stenosis, pulmonary hypertension, and hypertrophic cardiomyopathy. What do you think this patient has got? So most of you are with B, B and A. So mostly B, A. Okay. All right. Most of you are not wrong. So what we have seen from here, first of all, let's have a look. So symptoms are shortness of breath and orthopnea, right? So that's a feature of heart failure. Then on exam, bibasal crepe, bilateral ankle edema. So it confirmed that yes, this patient has got a congestive cardiac failure. So that's what we know so far. Now, definitely heart failure doesn't have murmur. So most likely this murmur has something else. So systolic murmur best heard at the apex. At the apex, what murmur we can hear better? Mitral. Now, knowing just that, understand why our previous murmur class makes sense now. Just by knowing that particular information, you can even come to the diagnosis just on that. Because none of this murmur will be heard at the cardiac apex. So that's why those little small knowledge sometimes can really help to come to the diagnosis in exam. Because we know at cardiac apex, we will only get a mitral murmur. Either it's a mitral stenosis or a mitral regurgitation, right? But still, we want to make sense why this patient has mitral regurgitation and how it is causing heart failure. What's about this irregular pulse? So this patient also got atrial fibrillation because she has got a irregular pulse. So what happened in here is that this patient has got mitral regurgitation. So if you remember our discussion about the cardiac pathophysiology, mitral valve is a one-way valve. It is supposed to take blood from the left atrium to the left ventricle. And that one-way valve should stop any regurgitation of blood from left ventricle to left atrium. But in regurgitation, this valve does not work properly. So there will be more and more blood which will regurgitate back to the left atrium. So there will be left atrial dilation, right? And there is more and more fluid overload on this area, which eventually causes backflow of the fluid into the lung, causing this heart failure. Okay, so that's how mitral regurgitation left untreated, and if it becomes severe, it will end up causing a heart failure. Now, how it is connected to F? Because there is a lot of blood volume in here, there is a lot of turbulence, and also the blood is getting collected here and is staying here longer time. When there is stasis of blood and blood is not moving, it tends to form clot. That's one thing. And also with mitral regurgitation, gradually, because the atrium gets dilated, the cardiac remodeling starts in here. When cardiac remodeling happens, the electrical impulse also get disturbed. And then there will be this abnormal electrical impulse coming up from this spot, causing the AF. Okay, so MR is very commonly associated. So MR commonly leads to volume overload, atrial fibrillation, and congestive cardiac failure in older patient. Okay, so that's how we can come to the diagnosis. Now, if we rule out other things, aortic stenosis, what type of murmur it is? Ejection systolic murmur. Yes, good. Tricuspid stenosis, do we know what type of murmur it is? It's the same murmur of MS, mid-diastolic murmur. Pulmonary hypertension doesn't have murmur. Okay? Hypertrophic cardiomyopathy usually should not give you a murmur, but can it give a murmur, hypertrophic cardiomyopathy? It can. Okay? So it can give a murmur. The murmur that it gives is called ejection systolic murmur. It's a harsh murmur And the murmur has this whooshing sound. Okay, it's a harsh mid-systolic or ejection systolic murmur, and it has this crescendo decrescendo type of murmur. That means it gets louder and then it gets softer. So it's a crescendo decrescendo mid-systolic murmur, and it is best heard at the left lower sternal border. Okay, so same ejection systolic or mid systolic. So mid systolic murmur best heard at the left fourth sternal border. Okay, why we are not thinking HOCM in a 72-year-old? What is really, really important? Yes, HOCM is a genetic condition and it's usually happen in younger patient. Yes, patient will, if left untreated until 72, that patient might not live that long. That's one thing, but HOCM patient has a classic symptom. They get syncope. They usually come to you not with all of this, they come to you with loss of consciousness. And they have a pattern of cardiac syncope, which means that cardiac syncope is loss of consciousness which happens suddenly. So out of nowhere, patient was maybe running or doing it or playing some sports. Out of nowhere, patient will just lose consciousness and then sudden regain of consciousness without any confusion after that. So sudden syncope followed by sudden regain of consciousness, that's usually goes with cardiac syncope, and that's usually the presentation for HOCM. And it's more younger patient, and there will be some family history of sudden cardiac death. Like there will be someone in the family who died like when they were very young. So those things usually will be there when we think of HOCM. Making sense, everyone? Not making confused? We already took a class, Rafa, on murmur. That was our last class. There is nothing we can do to help you memorize murmur, but I did a bit of a discussion about the easiest way to remember them. So if you haven't done that class, please go through that. Next question. We have got a 50-year-old man presents with central chest pain on exertion, and it is relieved by rest. The pain has been occurring for the last 3 months, not associated with rest pain, no previous cardiac history, physical examination is all right, resting ECG is normal. What is the most appropriate next investigation? So they're asking the next investigation in a 50-year-old who has a central chest pain on exertion. Chest pain on exertion, we should not forget that this is likely to be cardiac. Now, if it is a, let's say we are thinking that this is an angina because the pain has a relationship with exertion. Patient doesn't have any history of cardiac problem and ECG, the resting ECG is normal. What are we going to do next? So this is a patient who has possible angina and we want to confirm angina in this patient. We can't confirm it because the ECG is normal as a baseline or resting. So we want to make the patient stressed to see that when they are stressed, do they get angina-like pain? Do their ECG shows any changes like any ST depression or any T inversion? So you want to see that. So how we are going to see that? We have coronary angiogram, exercise stress test, CT coronary angiography, troponin, echocardiogram. Definitely at the moment, if a patient has chest pain right now, then yes, we can do troponin, but right now the patient doesn't have it. It's not the case because it only happens on exertion. Does echo, so the question that we need to ask in this patient that I want to do a stress test. So if I want to do a stress test, option in here is we have echo, we have exercise stress test. So if there is no baseline ECG abnormality and patient is able to exercise, we can just send the patient for an exercise stress test. Okay. The question did not say anything about whether patient is able to do any exercise or not. Now, if they were going to, like, if that was something in the examiner mind, they would write in here that patient has severe osteoarthritis of the knee joint. Then that should click in your mind. Definitely that patient can't run on a treadmill. Then I will have to send the patient for chemical stress test. So this is where your knowledge of all those stress test related discussion that I had with you in the first class, this is where it will come in handy. Okay. So this patient, definitely we need to do a stress test to find out whether the patient has any kind of inducible ischemia, which means that if a patient run on a treadmill, is the patient is going to get the symptoms of angina. So this is next most appropriate. If question asks most appropriate definitive, that's going to be angiogram. And usually for this kind of patient, before you go for invasive angiogram, you will choose the CT angiogram first. Okay. So if they're asking about the best, most appropriate, definitive, that's the time. Most appropriate, we would do a CT coronary angiogram in that patient. Now, if they say definitive, definitive means like the best, like what's going to be the best thing. So in case of definitive, sometimes if we are getting a patient with a ongoing chest pain or chest pain right now, like then we go into that PCI related thing, which is different. But all we want you to understand that what does the next mean? Next means that you have done something, you have done the resting ECG. What's the next thing? Next thing in that case is exercise stress test or any form of a stress test based on the patient's other history. If they're asking most appropriate, best, definitive, then we go for angiogram. Okay. And troponin, virally, it will be only if the patient right now, patient has chest pain, then yes, we would do it. A 42-year-old woman presents with sudden onset shortness of breath while eating dinner. Very important and common question. So, sudden onset shortness of breath while eating dinner. She appears anxious. On exam, she is tachycardic, tachypneic. Saturation 94. Chest exam is unremarkable. ECG shows sinus tach. Which of the following is the most likely diagnosis? What do you think? So we have got a 42-year-old, sudden onset shortness of breath. She's tachycardic, she's tachypneic, saturation is low. So everything is there. And we found ECG showing sinus tachycardia. Okay, let's come into the exclusion criteria. Is it an acute MI? Why not? There is no chest pain. Yeah, that's easy question, right? There is no chest pain in this patient, so not MI. Can it be pneumothorax? Why not? Again, pulmonary embolism has chest pain. This patient doesn't have chest pain. Is there anything else you can think of? Chest clear, very good. If it is a pneumothorax patient, there will be chest finding, there will be reduced breath sound, hyper-resonant percussion. Can it be panic attack? It can be. Definitely, that is a possibility, but you don't diagnose a patient as panic attack unless you rule out the organic cause. In exam, you can't just assume that this patient has a panic attack without ruling out the other possibilities. This patient has hypoxia, tachycardia, tachypnea. So you can't just say that this patient has panic attack and go home and just breathe out in a bag. Can you tell that without doing test or anything? Definitely no. So how can it be your diagnosis? So you can only come to that panic attack as a diagnosis when you rule out other possible organic pathology. So I know, yes, questions say she's anxious. That is a trap. That trap is very common trap. Most of the candidate will think that, well, the patient is anxious, so definitely it is psychological. So let's just put it as our answer. No, you can't. That's the problem, and it's a very common trap for candidates in the exam. And that also shows your experience as a doctor. If you are not an experienced doctor or if you have lack of knowledge, then you will choose panic attack in here. Okay. Aortic dissection. Definitely, this patient needs a chest pain. Without chest pain, aortic dissection is not our diagnosis. No, eating dinner is nothing in here. So this is a sudden shortness of breath. Eating dinner is just to make you confused. So that pain can happen anytime. Okay. So the PE shortness of breath is not related to exertion. It's not related to anything. It can start suddenly. Okay. So this patient most likely diagnosis based on all the thing we have got is pulmonary embolism. So foreign body aspiration and chest examination is normal. And patient would not have any choking. That's very rare. So S1, Q3, T3 is very rare. Very rare. Have you ever seen a patient with PE with this pattern of ECG? I haven't. And if I would see that, I would be really lucky to see that. I don't want to say that, but yes, that's very rare to have S1, Q3, T3. What's the most common ECG finding for PE patient? Sinus tachycardia. Sinus tachycardia is the most common feature. How did we rule out panic attack? We just mentioned that this patient, yes, there is a possibility it can be a panic attack, but can you say that this patient has a panic attack without excluding pulmonary embolism? They're asking what's your most likely diagnosis. If you can't say that I am fully sure this patient has got a panic attack from this scenario, you can't choose panic attack. Not necessary, it's not a major symptom. Yes, PE would have chest pain most of the time, but the most common symptom of PE is shortness of breath because it's the lung that gets affected. So if we think of pulmonary embolism, what's our next investigation after ECG? CT pulmonary angiogram. There is a lot to think, lot to know about it. I'm not going into respiratory system today. When we discuss the respiratory system, I will discuss in detail about the investigation, the Wales score and all, but not today. Fat embolism would have, first of all, fat embolism comes after some major trauma to the lower leg. So it's usually trauma related, it's long bone fracture. And then those patients, along with shortness of breath, they also get mental confusion. They get petechial rash, usually around the axilla. Okay, so without any of those features, we would not think of fat embolism here. I haven't confirmed anything, Ash. The question is most likely diagnosis. You ask yourself, if this patient comes to you and you are the doctor there, what would you do? Ash, would you send the patient home without doing anything else? If you do, then you're in a real trouble. But if you don't, then that answers your question. Okay, so the question is not about confirmatory diagnosis. Question is about most likely diagnosis. And we never diagnose this kind of psychological condition in an acute unstable patient without ruling out any other organic pathology. That's not safe. Okay. Next, 58-year-old man presents with a 24-hour history of central chest pain, which has now partially settled. Excuse me. So 24-hour history of central chest pain partially settled. He has a background history of stable angina, hemodynamically stable, ECG normal, cardiac enzyme normal, echo showing segmental wall motion abnormality with mildly reduced ejection fraction. So echo showing wall motion abnormality. Wall motion abnormality means that maybe some part of the heart is not moving as it should be. And also there is a feature of low ejection fraction. What's the most appropriate next investigation in this patient? So it's already a known stable angina patient, but now having a ongoing chest pain for 24 hours. Are you worried about this patient? You should be worried because this patient has got an ongoing chest pain, already a known ischemic heart disease patient. So what are we going to do next in this patient? We have got exercise stress test, CT coronary angiography, then nuclear myocardial perfusion scan, that is the thallium scan, coronary angiogram. This is the invasive one. Okay. Repeat troponin in 6 hours. What is the diagnosis here so far? How do we know it is a MI? Troponin is normal, ECG is normal. Still now we would think it as unstable angina, right? Because we haven't got the troponin elevated yet. But definitely there is a lot of things going on in the heart right now because of the wall motion abnormality here. So what will give us the best picture in this patient? My question is that, are you going to send the patient for a exercise stress test or a nuclear perfusion imaging because you want to diagnose the patient more, or you want to do something invasive now? This patient will need a coronary angiogram, invasive one. Okay? The reason is, if you remember, guys, that was very important. So when you got a stable angina, like you've got a patient who has chest pain right now. Now you have done ECG, you have done TROP, still they are normal, but the patient still has got a little bit of chest pain. So that means the chest pain is not settled yet. If the chest pain was settled, then yes, we could do a CT angiogram. That's okay because patient's pain is gone, but patient still have the pain. That means still there is some myocardial strain going on. Okay. With that, you already did a echocardiogram, which has already gave us enough information that we need. Patient has got segmental wall motion abnormality. That means there is some ischemia. When there is wall motion abnormality on a echo, it suggests patient has got ischemia going on in the heart. Okay? No point of just doing a CT angiogram anymore, because CT angiogram will just give us the same thing, that yes, this patient has got 70%, 80% blockage. So for this patient who has ongoing chest pain, okay, so this goes into the acute coronary syndrome pattern. This is no longer a stable angina patient where you can do a CT angiogram, but this is a acute coronary syndrome given the patient still got the pain. For that patient, you will need to take the patient for an actual coronary angiography, which means the invasive coronary angiogram. And if the coronary angiogram shows there is significant blockage, then you go for a stent. Okay, so the basic that you need to find out, or you need to understand, that it's about the pain. So if a patient has got ongoing pain, which becomes acute coronary syndrome, and in acute coronary syndrome, we have got three things: unstable angina, non-ST elevated, non-ST elevated MI, ST elevated MI. We know that this is not ST elevated because ECG is normal. We know until now cardiac enzyme is normal, so it's still now it is not a non-ST elevated MI, so it is unstable angina. For unstable angina who has still pain for 24 hours, you did at least a echocardiogram to see what's going on, and you found an evidence that yes, definitely there is some ischemia going on there. That is enough to go straight to the invasive coronary angiography. If it's less than 70% block, then the patient will only have medical management. They will not put a stent in that patient if it is less than 70%. Problem is that you are just wasting time in that patient. This patient can end up getting a full-blown myocardial infarction if we wait. So we don't take that risk. Yes, a stent will be put on during the angiogram if needed. So you guys are thinking about stable angina still now. So remember, this is not a stable angina patient. This is an unstable angina patient. Unstable angina patient means that the patient still have a chance that he can get into a MI within hours. This patient, if we reperfuse this patient, he will not have reperfusion injury because he hasn't got a MI yet. In a stable angina, you would not do a troponin because the patient would not have a chest pain. Why we will do troponin in a patient who doesn't have a chest pain? So CT angiogram is for a stable angina. So you guys are all over the place. So let's see. So CT angiogram will be in a patient, let's say that we have got a patient who has a stable angina, and then we want to confirm whether it is angina, like whether it is a ischemic condition. So we send the patient for a stress test. And the stress test shows that yes, this patient, so a stress test can show that patient has got ischemia. So any of the stress tests that we have done will confirm whether the patient has got a ischemia or not. If it is confirmed that yes, this patient has got ischemia, then we can find out how much blockage is there. Does this patient actually need a stent? Then you do a CT angiogram. If CT angio shows more than 70% blockage, then you send the patient to a cardiologist who do an invasive coronary angiogram plus a stent. Okay? Did it make sense, everyone? It is a bit tricky in exam as well, because if you don't have the basic of this cardiac management, you will end up getting wrong answer. These are so important that I make sure that you understand them by your heart. Okay? So there is no always in medical science, Prachi. We always decide. We always decide based on the presentation. If patient's chest pain is better, it will no longer become unstable angina. If if the patient chest pain resolves, then sometimes we would not go for direct invasive angiogram. Even in unstable angina patients, sometimes if you do all the right thing, sometimes patients pain get better. Like after 24 hours, pain better, ECG normal, troponin normal. They will be sent back home. And then you will do outpatient CT coronary angiogram. It is the pain that's making us to do an invasive angiogram here. If patient did not have the pain, we would send the patient home and we would do an outpatient angiogram in that case, like a CT angiogram. So even though in here, so some of your question is that if we did not have an echo here, what we would do? So remember, you can't do a stress test in a patient who has ongoing pain, right? So you would not send the patient for a stress test. You would not send the patient for perfusion scanning. Any of those would not be the case because the patient has pain. So you will need to think at that time that whether are we going to do a CT coronary angiogram to know whether this patient has got a blockage, or are we going to do an invasive coronary angiography like a straight? Okay. Still, you would not do a CT coronary angiogram. So remember one thing, that CT coronary angiogram is not for acute coronary syndrome. When a patient has acute coronary syndrome, we don't do CT coronary angiography. It is usually done for a stable patient and who doesn't have a resting chest pain. Is everyone clear on this part? Okay. All right. I hope the time that we have expended, it is clear now. So even if this question did not have an echo, we would not go for a stress test because patient is unstable at the moment, and also not a CT coronary angiogram. For an unstable patient, we don't do it. We do it only for a stable patient. Okay. Because every minute that we are waiting, that patient's cardiac muscle is dying somehow, or we are putting the patient in a risk of having a full-blown ST elevated MI. A 24-year-old man presents with acute central chest pain that is worse on inspiration, relieved by sitting forward, no other medical history, vitals stable, heart normal, ECG shows widespread ST elevation with reciprocal ST depression in AVRV1, most likely diagnosis. This is the easiest for you, I guess. Yes, this is acute pericarditis because of global ST elevation and the pattern of the pain that get worse with lying down, better with sitting forward, or the pain that get worse with deep breath, that is pericarditis. Next question, 17-year-old male was running a race, suddenly collapsed on the floor. Luckily, someone was there and performed CPR as the patient did not have a palpable pulse and resuscitated him. So it's a sudden collapse on a 17-year-old. Upon arrival to the ED, it is revealed that his father died at 28. He is now alert, asymptomatic, ECG is non-eventful. He is anxious to go home. What would you do next? So what do you think this patient might have got? It's a young patient, had a sudden syncope. Father died at 28. That is a classic picture of HOCM. Can you give me another condition which can also cause similar kind of symptom in a young patient? AS is not common in young. AS more common in older generation. It's prolonged QT syndrome. Very good, Rais. So it's called congenital QT syndrome. So in congenital QT syndrome, they also can have their relative died at early age, and they also have the same thing, collapse and all of these. The difference between HOCM and congenital QT is when you do a ECG, you will see QT prolongation in this patient, whereas in HOCM, you will not get QT prolongation. Sometimes you can get left ventricular hypertrophy in that patient. So we understand ECG was normal. So that rules out QT prolongation. So it is HOCM. So for HOCM patient, you're not still confirmed, right? So what will you do next? Send him home and arrange an outpatient consult. Send him home only, don't bother. Admit, refer to the cardiology team. Send him home and do an outpatient echo, or just do a stress echo, because we don't need a cardiology. Just do an echo. You can't do a stress echo without a cardiologist. Okay? So you need a cardiologist to do a stress echo. That's the thing. So you can't just order a stress echo in the emergency department. It will not happen. This patient has HOCM. We did a baseline ECG, which was normal. Our next thing is to do a echocardiogram, just a baseline echo, resting echo. See if we can find out anything. But even to do that, this patient definitely can't go home. This patient just needed a CPR. Can you just send the patient home and do outpatient? No, you have to find out what happened. So you have to admit this patient, get a cardiologist, and get a full picture before we can send him home. Okay? Good. Similar kind of question. A young athlete presents with a history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient's father had sudden death at a very young age. What is the initial treatment? Verapamil, septal myomectomy, defib, low molecular weight heparin, adenosine. So now I will show you how many ways a question can come in exam. So it's the same thing. Young patient, sudden syncope, father had died. So it's HOCM most likely. What will be our treatment for HOCM? What kind of heart failure we get? Diastolic kind of heart failure, right? So we know in diastolic heart failure or in HOCM, we want to reduce the heart rate so that heart gets enough time to get refilled. So we are going to give him either a calcium channel blocker or a beta blocker. So find out if any of these is here. We have got verapamil, which is the calcium channel blocker. Okay, so we'll give the verapamil in here. That's the treatment. We already discussed all of this. A young girl, 15-year-old, collapsed at exercise. Her father had HOCM. After ECG and echo, you found no abnormality. So same, HOCM, you did a ECG, you did a echo, nothing is there. But father had HOCM, patient already collapsed. You can't be sure. There is still some other test to do. What will you do next? Yes, you need to put the patient in a stress because it happens at exertion or at exercise. So make the patient stressed and then do an echo, you will find out the problem. What problem we will be looking for? So in the echo, we'll be looking for septal hypertrophy. We might also find out that patient has left ventricular outflow obstruction, LVTO. Sorry, LVOT. So left ventricular outflow obstruction, and we get the septal hypertrophy, which is the basic pathophysiology of this condition. That's what we are going to get in an echo. Now, what if even a stress echo is abnormal? Anything else we can do? Not halter. So even a stress echo is abnormal, then we have an option of doing a cardiac MRI. We only do it if a stress echo is inconclusive. If these are, let's say that it confirmed, so either a stress echo or a cardiac MRI confirmed HOCM, we also do a genetic test for that patient to see that if the full family needs a screening. So that's what's the investigation of HOCM goes. Okay, so first baseline ECG, then just a normal echo. If it's still inconclusive, we do a stress echo. Now, to understand why a stress echo can find this out and not baseline ECG, baseline echo or resting echo, it's the knowledge of HOCM. If you don't have the basic, you will not understand this part. So you have to remember that in HOCM, the septum gets hypertrophied like this. Okay, and it gets so much hypertrophied that it blocks the flow of blood from left ventricle to the aorta. Okay, that's why we call left ventricular outflow obstruction. So the septal hypertrophy is that much. There is not much of a space left in the ventricle, and it also blocks the aorta. So the blood needs to go from here to aorta, but the hypertrophied muscle actually blocks that part. Now, when the patient is exercising and under exertion, what happens? Our heart works more, heart works faster. And if heart works faster, what will happen? The systole or contraction will happen more and more. If contractions happen more, then the patient will have more symptoms because now there is definitely during exertion, patient is contracting it more than normal, and sometimes it can produce the symptom. And also patient, we can see that patient is feeling a bit of like funny fuzzy on the head, and when we do the echo we can find out that yes, patient is feeling funny because the left ventricle or the left ventricular outflow is getting obstructed by this septal hypertrophy. So it just, if it is a small or if it's not a huge hypertrophy, then without exercise, patient will not get symptom. Only when they do the exercise, then because heart is contracting more, it's not having much of space anymore. Then we can induce the symptom. Okay. Yes, it is dynamic. So LVOT is dynamic in the initial stage of HOCM. It's not always there. And it is not Holter because Holter is for arrhythmia. So if a patient has got some form of arrhythmic disorders. When we will discuss palpitation, you will understand that. Then we do the Holter monitor. Clear, everyone? A 9-year-old male was playing football, suddenly collapsed on the floor, and upon arrival to the ED, it is revealed that father died at 28, now alert, asymptomatic. What will you do next? So this is same question, but a different option and different answer. And I believe you will get it right. Yes, definitely. This patient did not even have a ECG. So you will need to do the ECG first. So that's how question changes in exam. It will look like the same question, but always there will be some changes. There will be always something that will surprise you. So having a good knowledge of a step-by-step approach is the main thing that you need to learn. Okay? And it's difficult to know because the guideline is not that good anywhere in Australia. How we make these things easy for you is because we are practicing here and we know the step-by-step guideline, and that's how it becomes easy for us to show you. But without working in here, someone teaching AMC, MCQ or clinical, it's a disaster because there is actually no proper guideline you will find out anywhere. And the guideline you follow in your own country is quite different from Australia. Okay, because there are lots of facility in here and there is lots of chance to do any kind of investigation that we want to do. A 16-year-old male who presents with ejection murmur in second left intercostal space, which of the following is likely to be the diagnosis? This one you need to use your brain, you use the pathophysiology that you have learned, and you will come to the right diagnosis. So it's a 16-year-old ejection murmur, second left intercostal space. All of this option has got atrial septal defect. Now we discuss this pediatric cardiology in pediatrics. So we will have a discussion on that later. But definitely this patient has got ASD, but that's not the problem. We need to find out the other. So is it aortic stenosis, mitral stenosis, pulmonary hypertension, or aortic regurgitation? So think of few things. Mitral stenosis. Where do we get it? Left fifth cardiac apex, but it's on the second left intercostal space, so it's out. Aortic regurgitation, where do we get it? Left fourth intercostal space along the sternal edge. How about aortic stenosis? If you remember, this was the discussion we had. Aortic stenosis is best hard on the right side, right second intercostal space. So that's also not the case. So even if you know how to just, that's when in exam sometimes it becomes difficult. Then you use your basic, you use what you know. And sometimes just using that, whatever left is your answer. And then sometimes you will be able to make sense out of it. Now we know that our answer is ASD with pulmonary hypertension. Now you can think why it is the case. So atrial septal defect means there is a defect in the atrial septum, right? So when there is an atrial defect, so initially what happens? We know that this side, the left side of the heart, is more pressured area. And fluid always moves from more pressure area to the less pressure area, right? So fluid will move through this defect, or blood will move through left atrium to right atrium because of this defect. But ideally there should not be any mix. But because of the defect, blood can now come to this side. When it comes to this side, what happens is that more and more blood is coming to the right side. More and more blood then goes to the right ventricle, and more blood will then go to the pulmonary artery, causing a pulmonary hypertension. Because ideally there should not be that much of a blood. So blood is coming from all the part of the body on the right side. Now blood is also coming from the left side to the right side. So there is too much volume on the right side of the heart. And that also needs to pass through the pulmonary artery, which will eventually cause pulmonary hypertension. Okay? Clear? So ASD, VSD. So VSD is the main, like the commonest murmur, and the second commonest valvular heart defect is atrial septal defect. And atrial septal defect will give you this ejection systolic murmur. So that's the murmur we have got here. The ejection systolic murmur is the murmur of the ASD. Sorry. So this ejection murmur that we see here, it is the murmur of ASD, not anything else. What's the murmur of VSD? Pansystolic murmur at the left lower sternal border. So VSD gives us pansystolic murmur at the lower sternal border, and ASD gives us ejection systolic murmur on the upper sternal border, also the left side. Okay, move on. A young guy, while playing cricket, so young guy suddenly had a syncopal attack without any convulsion. Soon he spontaneously recovered, started feeling, continue playing the rest of the game. What was the cause? Vasovagal, cardiac, epilepsy. Epilepsy is unlikely because there was no convulsion. Neurogenic. For a young guy having a neurogenic syncope, uncommon. Postural hypertension. Postural hypertension, if it is the case, they will say that patient get dizzy or lightheaded when they change their position. All right, because when they stand from a sitting position, blood pressure drops. That's postural hypertension. This is nothing about this. Now, is it vasovagal or cardiac? We know that cardiac syncope will happen suddenly without any symptom or without any prodromal symptom, and then patient will lose consciousness and then regain consciousness without any confusion. That's cardiac. What's vasovagal? Vasovagal happens slowly. So they get a prodromal symptom. So let's say patient was running in a hot sunny weather, suddenly started to feel cold, clammy, sweaty, trembly. So they have these few seconds of prodromal symptom, and then they fall. Then they lose consciousness and then gradually regain consciousness. So when there is a prodromal symptom, then we think of vasovagal. So this patient has got a cardiac syncope. For a young guy having a cardiac syncope, HOCM should be on your top list. Clear? Let's have a look. A 45-year-old male presented to the emergency department with left-sided chest pain radiating to the left arm and jaw. There is no ECG changes. Troponin is negative 4 hours since the onset of pain. He has been on sildenafil for erectile dysfunction, metformin for diabetes, ramipril for hypertension. What would be the most appropriate next treatment? So I always say that think of the when we actually manage a patient or when we get in the exam any question related to acute coronary syndrome, think of survival benefit. What causes survival benefit in a patient? That should be your choice. So it's a 45-year-old male present to the ED, left-sided chest pain radiating to the left arm and jaw. There is no ECG changes, troponin negative, has been on sildenafil. Now, if a patient is on sildenafil, means Viagra, we can't give them nitrate, at least not within 24 hours of the last use. So nitrate is contraindicated because it can cause massive hypotension in that patient. Beta blocker is not needed at this stage. So what is this? What is your diagnosis? Patient having chest pain, and we know that it's been at least 4 hours. Definitely not a stable angina. So think, because a stable angina will not be there for 4 hours. So this is an acute coronary syndrome. No ECG change, no troponin. But you can't say it's non-ST elevated MI. Have you got troponin? No. So it's unstable angina. So unstable angina, we still need to know whether this patient has got a non-ST elevated MI. So this patient will definitely get repeated ECG, repeated troponin. But until then, what is the most important thing at this moment? So we have got paracetamol is definitely not the most important thing. Between heparin and morphine, this is where the questions, or this is where it gets tricky in exam, because both of them are equally correct. So we would choose the best option which can save the patient's life, which can be more important for the patient. So in an unstable angina, in a non-ST elevated MI, yes, heparin is really important for pain control, but in that case, exam would say that patient has got severe chest pain. If in exam they want you to choose morphine as your answer, they would always say severe chest pain, or they will give a score. They will say that patient has got pain score of 10 by 10, 8 by 10. That means patient is in a lot of pain. That patient, definitely we want the pain to go. But this in here, they did not mention that is it severe, is it a mild chest pain, nothing. In this case, the best option is heparin, because heparin will prevent further clot formation. Okay, so why we think like that? I know that this is confusing always, and this also confused us. So we always think that whether to choose heparin or morphine in this patient. But so far, from all the questions, all the things that we have discussed, and according to all the guidelines that we have shown you, the guideline always say that you choose the best option in cardiac cages. So especially for acute coronary syndrome, option is like this. You give aspirin and then you think what medication you have in the list which can help the patient to survive or which can stop further problem. In an unstable angina patient, we would not do angioplasty or anything like that. So what else? If there was a dual antiplatelet like clopidogrel, yes, definitely that's one option. Even better than clopidogrel is heparin. Okay, so both clopidogrel and heparin we will choose in this patient. This is not premature treatment. This patient has ongoing chest pain for 4 hours. Okay, patient has diabetes, patient has hypertension, so cardiac risk factor. It's a 45-year-old, left-sided chest pain radiating to the left arm and jaw, classic cardiac pain. It is not premature. What you're doing, you are saving the patient. Okay, if aspirin is an option, definitely aspirin. Okay, aspirin is always the first thing we would choose. After aspirin, in unstable angina or non-ST elevated MI, because you don't do immediate angioplasty in those patients, in exam you look for heparin because that's most of the time is going to be your answer after aspirin. Okay. So you're choosing heparin in this patient based on the fact that heparin has more survivability than morphine in this patient. And also if there was severe chest pain, we would definitely give morphine in that patient. Okay. A 72-year-old male presented with severe chest pain radiating to his back. On cardiac exam, you noticed diastolic murmur, chest X-ray, wide mediastinum, ECG is given. What's the most appropriate management? So severe chest pain radiating to the back with wide mediastinum, that's aortic dissection. Let's have a look to the ECG. Now, definitely it's difficult for you to learn ECG in one class like this, but to give you a slight idea, sorry. Sorry, my laptop battery is down. That's why it's just getting hanged. I'll just put a plug there. Just 1 second. All right, let's have a look to the ECG. So if we look over here, first, any patient who has chest pain, we look at the chest lead. So look at V1 to V6. So this is the isoelectric line, and that's the ST. Now, again, as I said, that there will be a separate ECG class. We will show you what is ST, elevation, depression. Tonight, it's not in our scope to discuss ECG. So just a quick thing. So V1 has got ST depression, V2 ST depression, V3 ST depression, V4, V5, V6 that has got ST elevation. Okay. Lead 1 is okay. Lead AVL has got ST depression. But what we see here, lead 2, lead 3, lead AVF, that has got a significant ST elevation. So this patient definitely have got a inferior MI with a bit of lateral component. So inferior lateral MI. So this patient is not just having a aortic dissection, but also the patient has got inferior MI. So it's together, both. So that's the worst thing to have. So aortic dissection plus the patient has got an inferior MI. So what will be the most appropriate management for that patient? Give altiplase, aspirin, morphine, beta blocker, arrange for transesophageal echo, refer the patient to cardiology, consider urgent MRI of the cervical and thoracic spine. That's not the case. Can we give altiplage like a thrombolysis in a patient who has aortic dissection? No. That's an absolute contraindication, right? So that is out. We have option of referring the patient to cardiology clinic. That's nice and easy. We can definitely do that. But bef before we do that, we need to at least arrange something for this patient. We just can't wait until the cardiology come here. So what you would give in that patient? Aspirin and morphine, beta blocker, and echo. So if you remember, in aortic dissection, most of the aortic dissections are type B. And yes, we can't give aspirin in this patient because it will increase the chance of bleeding. So your option is C, which is morphine, which will give us the pain relief, beta blocker, because it will reduce the blood pressure. We know that in aortic dissection, the first line blood pressure lowering medication is IV labetalol, which is a beta blocker. So you give beta blocker to keep the blood pressure down. And definitely you need to arrange a transesophageal echo to confirm the diagnosis. Okay. So that is the treatment, or that is the most appropriate treatment in this particular patient. So that's the aortic dissection widening of the mediastinum. An elderly man with multiple fall during the day, especially in the morning after waking up. So multiple fall, especially in the morning after waking up. ECG found left ventricular hypertrophy, multiple ventricular ectopics, orthostatic or postural hypotension was also noted. How will you investigate further? So elderly patient having multiple fall, the number one cause is orthostatic hypotension. Okay. So the option in here is repeat the blood pressure in supine and prone position, 24-hour halter, serum electrolyte and echo. What would you do in a patient who has orthostatic hypotension? ECG has some ventricular ectopic, which is arrhythmia, left ventricular hypertrophy. So something is going on in the heart, right? Orthostatic hypotension was also noted. Now, if we want to confirm postural hypotension, we can't just rely on a single blood pressure. We have to do multiple to confirm. Now, if we want to confirm it, we will have to do a repeat blood pressure. Now, don't choose A yet. Look at this. What happens? Like if we ask the patient to lie on supine and prone, does it do anything? No, it doesn't. It's not postural hypotension. For postural hypotension, we will need to check it. We will need to ask the patient to sit. So when the patient sit, we will check the blood pressure. and then patient will stand, we will check the blood pressure. And postural hypotension will be diagnosed if multiple reading shows when patient stand from sitting position, blood pressure drops more than 20 systolic or more than 10 diastolic. So not a single reading. Single reading can show that, but if multiple, at least minimum 3 readings showing that patient has got this standing blood pressure drops like this, then we can confirm postural hypotension. What is the most common cause of postural hypotension in an elderly patient? Polypharmacy. Polypharmacy is the most common cause of postural hypertension. So elderly patient will be on multiple volume depleting medication. Like they might take ACE inhibitor for blood pressure. They might be on a diuretic for maybe heart failure or something else. And then they have a benign prostatic enlargement. So we have given him tamsulosin, so alpha blocker, and patient just dropped. So multiple volume depleting medication is the number one cause of postural hypertension in an elderly patient. So always look for multiple drug, especially the drugs which can deplete the volume. That's usually the cause. Okay. And lots of other causes are there, but that's the most common one. Now we still haven't got what we need to do further for this patient. So ECG found LVH, left ventricular hypertrophy, and multiple ventricular ectopics. So electrolyte is not going to help here because there is nothing indicating that why we need to check electrolyte. The question is, are we going to do Holter or are we going to do echo in this patient? What do you think? So you have got two options to choose basically, and both are equally correct. But the question is which one you would choose in exam. Okay, so the main thing is that when we get an elderly patient with fall and they have got some cardiac issues, like they have orthostatic hypotension, they have this ECG showing LVH, multiple ventricular ectopics, it is usually arrhythmia, like the arrhythmia that we are not being able to find out in a resting ECG, because most likely there are some arrhythmia, maybe a heart block, maybe patient is going into some fibrillation. So something is happening, which is what we are not able to find out on a resting ECG. So the main thing is that it's remember that if an elderly patient comes to us with recurrent fall and they have some ECG abnormalities, LVH, multiple ventricular ectopic, our first thing to rule out is arrhythmia. Okay. Yes, echo will rule out a structural abnormality. But we already know this patient has got a left ventricular hypertrophy. Okay. Now, we always find out what is priority here. Are we thinking this patient has got a heart attack? Or are we thinking this patient has got a heart failure? Because that will be what we will find out in an echo. Right? If a patient has heart failure and patient is falling because of heart failure, we would definitely have some other finding of heart failure. The symptoms will be much more than what it is. Okay? If we are thinking ischemic heart disease, patient would have a chest pain, at least some chest pain or shortness of breath. So what else we are looking for in the echo? Valvular heart disease, right? If it is a valvular heart disease, patient would have at least murmur during our examination, or patient would have some other findings, like let's say that in a patient who has aortic stenosis, which is the most common valvular disease in elderly, patient will have syncope, that this patient has got fall. We don't know if it is loss of consciousness, but also they will have intermittent chest pain. They will have shortness of breath. So valvular heart disease, usually shortness of breath is very common for them. Okay. So if you think logically, what is the more chance for this patient to have? More chance is that this patient might have a arrhythmia instead of any of the others which we might find out in an echo. Now, that doesn't say that we will not do echo in this patient. We will do echocardiogram, but the question is what to do next. Okay, in the next step, we will do a Holter monitor to rule out any arrhythmia that we can't find out in a baseline ECG. And if still Holter is normal, then we will send the patient for an echo. Okay. Clear? All right, you can have a 5-minute break. I understand that these are quite difficult, right? And trust me that you guys are not doing any hard work. All the hard work is done by me. It's very difficult for making you understand these things. Yes, so in this question, we need to find out what type of arrhythmia patient might have. So it could be any arrhythmia. Okay, Holter is only done to find out arrhythmia, nothing else. All right, let's take 5-minute break and we'll come back after that. Thank you. All right, everyone, let's be back. So this is your next question. A young patient has been getting multiple lightheadedness and dizziness. His clinical features are normal. Chest X-ray, ECG normal. Holter monitor shows ventricular ectopics. What will you do next? So we haven't discussed ventricular ectopics yet in the class, but ventricular ectopics are some kind of abnormal beat in between normal beats. And it's very common to have it. Okay, but this patient has got lightheadedness, dizziness, but his all other symptoms are normal. Clinical features good, chest X-ray, ECG good, Holter good. So what will you do? Okay, this is from John Mortag. Read this and then you will answer again. So premature ventricular complex, these are usually asymptomatic. They occur in 20% people with normal heart. Some of the drugs are there which can cause it, most commonly digoxin. And sometimes, if needed, we will look for ischemic heart disease, mitral valve prolapse, thyrotoxicosis, and LVF. Have a look if symptomatic, but otherwise well, with a normal chest X-ray and ECG, reassure the patient. Okay? Drug therapy, never start drug treatment without an echocardiogram. And if we need to give treatment to this patient, then beta blockers such as atenolol or metoprolol can be used. So the question came from this line. If symptomatic, our patient has symptom, headache, lightheadedness, dizziness, but otherwise well, clinical feature is normal, chest X-ray normal, ECG normal, chest X-ray, ECG normal. What do we do? For a young patient, if the ECG is normal, if chest X-ray is normal, we are not looking for anything, because what echo would give us? Why we're doing an echo? To look for whether the patient has got a valvular heart disease, right? If it is a valvular heart disease, we would not get a murmur. Yes, we would get a murmur in our clinical exam if it is a valvular heart disease. Now, it's totally different if it is an older patient. In older patient, there is always chance of having a structural problem like ischemic heart disease. A lot of things can happen in older patient. For older patient with this symptom, we will do other tests. We will do echo. Even if we need, we do other tests to find out everything. Okay. But for a young patient, that is completely different. For a young patient, they can be symptomatic, but we don't normally start them with treatment for this. We just need to reassure the patient that your X-ray is normal, your ECG is normal, and having a ventricular ectopic is very, very okay. So only time we would really do an echocardiogram if we found that patient has got some murmur or some abnormal clinical examination finding, patient ended up getting like complete loss of consciousness, or patient had a family history of sudden cardiac death. If any of those were there, like any other things that would say that yes, we should go for more, then we would go for a plain echo. So as part of John Murtagh, this is exactly what the question has given you. Symptomatic patient, but ECG chest X-ray normal, we reassure the patient. We don't need to do an echo. Okay. quite tricky if we don't know it. So a scenario given of multiple drug. So this is how recalls looks like. Incomplete question. So let's make it a bit complete. We have got a patient who is 60-year-old male on multiple drug, including ramipril, amlodipine, hydrochlorothiazide, celecoxib. And the question is asking which of the combination out of these three will cause muscle weakness without tenderness. So we have got ramipril hydrochlorothiazide. Ramipril is a ACE inhibitor. We know H inhibitor causes hyperkalemia. So potassium will be high, but thiazide causes hypokalemia. So together it counteract. Amiloride, which is a potassium sparing diuretic, will increase the potassium. Ramipril also increases the potassium. So together, both of them can cause hyperkalemia. Celecoxib, NSAID. Sometimes, yes, NSAID can increase potassium, but not a lot. Let's say it did. But again, thiazide will counteract that. So this patient has got likely to be a muscle weakness from hyperkalemia. Remember, both hypo and hyperkalemia can cause muscle weakness. It's not only hypokalemia. Okay. So pharma drug interaction is a very common exam related question. That's why I say common medication, you need to know their side effect. Not all side effect, common side effect, because it will be tested in the exam. We have got a patient whose ECG is given and patient coming to us with chest pain, cardiac enzyme and ECG normal, blood pressure is stable. After 8 hours of observation, patient blood pressure goes down to 89/50. So now it's in shock. And ECG has supraventricular tachycardia with a heart rate of 150. So this is a SVT patient. We haven't discussed SVT in the class yet because it's a part of palpitation class. But to give you a slight idea, when we get a supraventricular tachycardia patient main presentation is palpitation, lightheadedness, and dizziness. And if you check their heart rate, that will be more than 100. And their rhythm will be regular. Now, SVT treatment depends whether the patient is stable or unstable. And how do we know someone is unstable? Someone is unstable if their blood pressure is less than 90/60, if they are confused, so acute mental confusion, if they have acute shortness of breath or severe chest pain. That group of patient who is unstable will go for direct DC cardioversion. DC cardioversion is kind of a shock. So we give the treatment which can save the patient is a DC cardioversion. So shock the patient to bring back the rhythm to normal. If it is a stable patient, for a stable patient, SVT treatment is a bit different. So your initial SVT treatment is vagal nerve stimulation. Now, vagal nerve stimulation can be done in a lot of ways. We can do vagal nerve stimulation by Valsalva maneuver. We can sometimes even, previously people used to do carotid sinus massage, which is no longer we do it. Valsalva is the main one that we do now. Then there are like immersion of the face into a cold water. So there are a few of them, but Valsalva is the main one. And there is a modified Valsalva that we do nowadays. Like we ask the patient to blow out through a syringe. Okay, we don't need to know that. Now, initial is vagal nerve stimulation. If the vagal nerve stimulation did not work, the next treatment is medical treatment. And the first line treatment is IV adenosine. No, there was break in my slide also. So adenosine is the first line of treatment, and we can try multiple time IV adenosine. So if initial dose did not work, we can increase the dose. Now I will discuss how we increase the dose in our class, but just know, yes, we can give IV adenosine multiple times, or if adenosine is contraindicated, we can give verapamil like calcium channel blocker. Even beta blocker can be given as well. Okay. If medical treatment fails, then our next option would be DC cardioversion. Clear, everyone? So that is the basic, but there's a lot to learn in between. We will go into bit detail, but for tonight, just know this. So this is a patient who has unstable SVT. For unstable SVT, what are we going to choose from here? We're going to go for synchronized cardioversion or DC cardioversion. When do we give defibrillation? When a patient has got ventricular fibrillation or patient has got pulseless ventricular tachycardia. These two cases we give defib. Okay. We have got a patient who is on digoxin, bisoprolol, thiazide. Long term, so let's say this is a patient who is 60-year-old male. Patient on digoxin, bisoprolol, thiazide. Long-term history of hypertension and congestive cardiac failure and AF. Stopped taking medication for 3 weeks while on vacations. Now patient presents with edema up to the knees. So there is now congestion in this patient. Raised JVP, that also means patient is congested, or we can call this as decompensated heart failure, but clear heart sound, so still no pulmonary edema. Blood pressure is okay, bit high. Pulse is irregular. We already know patient has AF, so that's why. What you would do as an initial management of this patient. So we have got a patient who is a known CCF patient, but went to a vacation and stopped all medication for 3 weeks. Now came back with decompensated heart failure. What will you do as an initial? Commence furosemide, mane, commence spironolactone, metoprolol, digoxin, bisoprolol, recommence all medication. Now, initial treatment, if they ask in a congested patient, initial treatment is furosemide. Okay, we need to, yes, definitely no metoprolol or bisoprolol. That's why we can't choose this recommence all medication, because if we recommence all medication, that also have bisoprolol there. Mane is morning, doesn't really matter. Okay, so if we start all medication to this patient, that means we are also starting the beta blocker, and beta blocker will make it worse. So for this patient, definitely we need to first make sure that congestion is treated. And yes, we will start all other medication except the bisoprolol. Okay, makes sense? But we always choose what is there in the option. In the option, the best option is furosemide, because we are not going to choose metoprolol, we are not going to choose bisoprolol. We are not going to give all medication at the moment. We already discussed that, Prachi. Prachi, did you do our heart failure case class? No, that's why. Do that class because we discussed these things in detail. We should not go into that basic again because it's just going to waste our time right now. So go into that class because we did have a very good discussion about heart failure, why we don't give beta blocker. So that will be the first thing that I would suggest you to go and have a look because this is an important thing to know. Spironolactone is not used as a diuretic to reduce the congestion. It doesn't work that fast, whereas furosemide works like fast, very fast. Okay. So this patient, we will start with furosemide. Basically, if there was an option of starting furosemide and all other medication except bisoprolol, that would be the best. Chest is clear, but if we don't stop the fluid congestion, within a week, this patient will come to you with a pulmonary edema. So are we going to wait for that? No. We make sure that whatever fluid the patient is getting congested, we'll just get it removed. Okay. That's for any kind of congestion. If the patient is congested, the treatment will have a furosemide in it. Furosemide is not first line for congestive cardiac failure. Furosemide is mainly the only part of furosemide in a heart failure patient is when there is congestion, nothing else. When there is no congestion, we stop furosemide. Okay. So that's basically all that we are going to discuss tonight. Okay. So I know you guys have a lot of questions about the course and all. So I want to go into that. I want to give you answers because tonight is your last free week session with me. And the next class will be done by another mentor for the random question solve. So before I finish the 2 week session, I want to go through with all of you about what course has to offer and how you can enroll into the course and all. Okay. So I'll show you from our portal. Just give me 1 second. So if you want to enroll into the course, this is the time because we are going to start the course in full rhythm after this free session is over. For many of you who are already the course student, please do not worry. I will update the full schedule just after this class. So we will give you the schedules and we will start the course in full rhythm. Now, if some of you who are not enrolled yet, but you want to know a little bit more, you want to know how to enroll, so you go into our website, which is firstaidamc.com.au. If you go there, you will be able to find out all of our courses here. Now, there is an old website also. Please do not go to the old website because we no longer use that. This is brand new and this is much better than anything that we have used before. So this is your course that you are enrolling. So 5 months extensive MCQ course. If you want to know a bit more, you can go in there. So our most affordable option is 599 Australian dollar plus 10% GST or admin fee. But there are several other options that you can choose. If you want to have more access to the portal, you can choose that as well. So the new batch has already started from 6th of January. It's a 5 months course, which we will end in at the end of May. We have done so many trial class. By this time, you should know whether this is the right course for you or not. And the classes are going to be exactly the same. Okay. So how we take classes, we don't change because I am going to take your class. So if you feel that no, you are enjoying my class, this is how the classes is going to be for theory session. For random question solve, we have three mentors who will take class for you as well, and they are very, very good. Once you get a bit more idea about the theory, you will start enjoying those sessions as well. The course summary, as I said, it's a 5 months course. Our classes happen minimum 3 days a week, sometimes 4 days a week, and class is usually 8:30 to 10:30 p.m. Sydney time. We do all classes as live session and we record this session. So if you can't do a live session, you can always listen to our recorded class and finish the course in that way. And half of our students finish the course with the offline recorded classes. Our course is based on complete theory. So we finish all the theory based on mainly John Murtagh, Kaplan Step 2 and therapeutic guideline and lots of other guidelines you will understand later on. Just like today, we also do theory-based question solve class. So we finish a theory like cardio and we do a cardio question solve. And then once you finish that topic, like you finish cardiology, then you can go into our portal and do a mock exam there based on cardiology. Cardiology, we have cardiac mock exam and also a mock exam based on ECG, which is really important. And then we have the random question solve classes, which happen 1 or 2 a week. We have extensive sample question already given in the portal for students, which I have discussed in the last 5 years with solved questions and all. And also you get recorded sessions of the last 3 years, which is a lot of question solve and classes. Now, we always discuss the updated and like the recent questions. So we will mainly focus on 2026 question solves in your course, but any other year, the classes that we have taken, you also get those recorded session. And you will never get this kind of extensive classes in any courses in Australia in this price. And that I can guarantee that. You also get recent sample question mock exams. So all the monthly we also add mock exam, like new mock exam every month as we finish a month. So you get unlimited monthly mock exam. There is a lot of mock exams to do in the portal. There are also full mock exams. So currently we have four 150 question mock exam, and we are in the process of adding the fifth one. You also get QBank. We do a lot of extra classes based on some important topics that are high yield for exam, like ECG, CTG, and all. All the recorded sessions will be there based on your subscription plan. If you subscribe for 10 months, you will get 10 months recording. If you subscribe for 15 months, the recording will be there for 15 months. And all the books will be given to you for as a soft copy. You don't really need to buy anything. We still haven't got John Murtagh 9th edition soft copy. Once we get it, then it will be available. But if you are in a hurry, you can always buy a hard copy from any store. Especially overseas, it's not very costly. But if you want to buy online, it is quite costly. New edition, we also do. So from your batch, there is also a course coordinator who will be in touch with you. So because we become quite busy with taking classes, especially me taking classes, answering many of your queries, we are having this is the for the first time we are also having a course coordinator for you who will be your first point of contact, who will be there all the time to answer any queries in the right amount of time. So that's what we are planning for you guys so that you get a bit more better experience as part of your queries. If you are short on time before your exam, we we give all the recorded session of the past batch that we have just finished, and with that you can finish most of the important things that you need to learn for the exam. Only thing that you need to do as a live session is at least the new question solve classes that you are going to have. So if you have 1 or 2 months to prepare, definitely. And again, if you pay the full amount, then you get the access of the last batch recording as well. All right, so the course fee is given in here. You get six like installment option, and the installment option is available up to 6 weeks from when we start the course. A lot of options are here. You can choose based on what you feel is like appropriate for you. Okay, so that's pretty much everything about the course. I can say that the course has everything that you need to pass the exam. If you just do what we are saying, there is no way you will fail this exam. Okay? No, you don't need to enroll in recall batch. It's the same. So the course has both theory and recall together. Yes, you will be able to do that. Manish, CPD, you will if you need CPD, you will need to enroll for the CPD during your course enrollment. That's very unlikely, Prachi. Can you please send a message to my inbox? Because everyone has got access within 2 to 3 days. Send a message right now. I will have a look what happened. Very unlikely why you would not get it. Did we ask for something like you haven't given some documents to us? That's why we did not approve it. So if you have waited this long, likely chance is that something is missing in your during your like submission of all the documents. So the classes for the paid students will start from next week. So both not they are not same. The Jivan, the study materials are not same. Some of them are in PDF, some of them are Word format, but PDF will be the most important ones. So planning for these classes is that once you finish a class, I want you to focus on the theory in the first 2 months of your preparation. So you mainly just go with the flow, which means whatever we are discussing, try to finish it within that week. Okay, that's the way to go. And how much time you need to do that, it's completely different person to person. CPD, if anyone needs CPD, you will have to enroll it during the enrollment time. High yield topics for AMC. Today, Jacob, I can't give you all the high yield topics. There are lots of high yield topics. Throughout the course, you will learn them because it's not only 1 or 10. There are hundreds of high yield topics. Pharmacology is not needed. Yes, so we will support you until the exam, but we don't do exam day recall, but we do recalls for every month. So you will be fine for any month that you're going for exam. So if you have already enrolled uh, in the class without CPD, but now you feel like you want to be enrolled, there is still the time for the initial 6 weeks. We can still change this for you, but after 6 weeks, we can't. So just send us a message and we will try to change your subscription to the CPD. So what happens is that once you make the payment, our admin will go through all the documents, make sure like no one is a scammer, and once that is done, then they will approve you. Once it is approved, you will get an email that your portal access has been approved, and then you will log in. That's usually what happens. So just after immediately after payment, you will not get the access. So it might take 2 to 3 days right now. Yes, if you miss class, recorded session will be available, and that will be available for 10 months. If you subscribe for 15 months, then 15 months. No, the CPD works in two ways. So one, that if you want a CPD point certificate from us, then you will need to choose the option in here. So you will see that there is a CPD certificate. So this option 3 and 4 has CPD certificate in it. So you'll need to choose either these two for CPD. But again, if you are member of any other CPD home like RSCGP, ACRAM, or any other, you can add our classes and get CPD from them. Then you don't need to choose this plan. Okay. And once we start the once we finish the free 2 week session, then every course related information will be given to the Facebook course group. It is different than our official group. So we will add you to our course group, and you will get all the information there about the classes and all. Dr. Shubro, once you register through an email, we can't give any access to any other email because it's already there in the portal. Okay, you can't change anything in the portal. Dr. Maimona, so the confirmation email should give you an idea that how to log into the portal. So we normally give the link of the portal as well there. So use the chosen device to log into the portal. And for the Facebook, please send me a message if you haven't been added yet. So if you read the email properly, you will see all the instructions are given usually there, that we ask you to send a message to me so that I can add you to the Facebook group. We also give you the link of the portal. So all the necessary information are usually sent to the email, but many of you actually don't read the full email. If you read the full email, you will always see that all the necessary information that you need to go from there is given there. Yeah, so only way to get the ETG is the subscription. There is no other way for ETG subscription. There is separate group for enrolled student, yes. So if any of you who have made the payment but did not get added to the course student group yet, please send me a message, okay? And that's very common that we are in the process of adding everyone. So nothing to get overwhelmed. It's a process. It takes time because there are hundreds of students who is also asking us a lot of information, a lot of queries. So we answer everyone in the time basis, but please understand that like three of our admins are working every day, doing like almost 10-12 hours to answer your queries. So, but again, like if you are in Australia, you will know that there is no provider who replies immediately. We can't because immediate reply is not possible. So there is always some waiting time for getting some reply from us, but it's not like 5 days, 6 days. So you usually get reply within 24 hours. So please wait for that time if you haven't heard from us. But definitely everyone's, if there is any queries, we will try our best to reply any of you. Okay. So any portal related queries, please send message to me. So you can always find my messenger if you go to the Facebook. So if you go to the Facebook, you can always find my ID. So you just send a message here. Any portal related queries, any admission related queries, send it to our email. That's usually more faster. Okay. So in a year, you need 50 CPD hours, okay, to cover that year gap. And the new course group, so the schedule for the paid student will be given to the course group. So that's the Facebook group where you will get all the schedules. And in the next few days, all of you will receive the necessary things that you need to know about the classes and all through your email because we are still finishing the 2 weeks free session. So that's why we haven't sent anything to you yet. But all of you receive the necessary email. So we will send everyone that what to do next, what's gonna happen. So you always get extensive information about everything. So nothing to be worried. Okay. Any questions? I'll have to look at it, Rafa. I can't fully remember which file has Cardiology QBank, but I can find it out for you. So you didn't find out the cardiology, right? Okay, that's fine. I'll have a look. So Prakash, have a look at the option 1 and option 3. So you just need to pay that extra amount that the difference between option 1 and option 3. So the thing is that you can only add CPD from a course on that year that you have done it. That means if you have done a course this year, you can only add this course CPD for only 2026. Let's say you are thinking that, well, I'm not going to add any CPD from this course this year, but I will need it in 2027, so I will add it at that time. That's not going to work. They don't allow that. So you can only add CPD for this year from any courses that you are going to do this year only. Does it make sense? Yes, so after completing the theory, you should go through the QBank by yourself to learn about some questions, understand those questions. Do not believe everything that is given in the Q bank. Some questions answer might be wrong. So now you have a very good understanding of what we are discussing in the course. You know about theory. If something looks wrong answer, you can always post it in your course group. Others can help you. We can also help you. Yes, so just text me for changing any of those CPD thing if needed. Always remember, if you are working as a doctor in your country at the moment, you don't need CPD. So please do not pay for CPD certificate if you are working doctor, because it will not make any sense. All of you will get a course completion certificate anyway, so that will be enough. But if you are not working as a doctor, that's the time you need a CPD certificate. Okay. Yes, mock test can be given, can be retaken. Lecturer will not be termed as a doctor at the moment. I know it hurts, Rafa, but it the only thing that will be counted if you're working as a doctor in a hospital setting or a GP setting. No, if you are intern doctor, that's fine. You don't need it. Saif, please send me a message. We'll have a look what happened. So Edward, Malaysia and AMC different. Okay. So you can't say Malaysia, I need 20 CPD point. Why Australia will need 50 CPD point? We are not preparing you for Malaysian. If you open your own clinic and you work there, then you don't have a work gap. But opening your own clinic doesn't mean you are working. You have to work as a doctor and show that you are working as a doctor. Radiology, that's a gray area. I'm not sure. Radiology should be fine because that's a part of a specialist as in Australia. I believe it is fine, but I am not fully sure to give this answer to you. I can come back to you. Okay, I can ask some of my colleague and see what they think. No. So doctor outside Australia, that's what I was saying. If you are working anywhere in the world as a doctor, you don't need a CPD. CPD means you are not working, and APRA just wants to know what were you doing during that time when you had a extensive work gap. If you have a work gap less than 3 months, please don't worry. It's fine. Even sometimes APRA doesn't get bothered with a 12-month of gap. If more than 12 months, definitely you need a CPD. Telemedicine is not counted, only hospital or as a general practitioner, like you're going to a clinic. The most ideal time to book exam if you follow this course will be end of the year. So anything from August to November. Dental clinic, if you're not working as a doctor in medicine, that's not counted. No, it will not count. Dental assistant will not be counted. Sorry. Dinesh, currently we are extremely busy about admitting candidates. If you have done duplicate payment, that will be dealt with, but right now it will not be. So please wait. You will get refund if you did duplicate payment, but please wait few days, okay? Because that's not in the urgency part for now. At the moment, in the next 2 weeks, we will be extremely focused on adding students into our portal, adding students into our Facebook group, making sure everything is in the right track so that they can start preparation. Anything outside of that, that will not be taken as a priority. Like if you are asking questions about CPD, we will not answer that as a priority right now because that's not a priority list. Okay. So we will always do the priority first. Someone who has done payment and did not get access to the portal, that becomes our priority. All right, so I hope you guys enjoyed our session. I hope that I will see many of you in our course. So, Nadeed, we are part of a CPD home provider. So the name of the provider is CPD Home under AMA. All right. We'll come back and we'll go from there. There will be a lot of questions, I'm sure. There will be a session on all these CPD and recencies and registrations. So many of your queries regarding that part will be dealt with during that class. So this is very confusing. So don't think you are the only one who is confused. Everyone is confused. So I will make it easier for you. So we always give that class for everyone to know about the pathway, registration, CPD, recency, all of those. So you should have that clear in your mind what to do because it's not only passing the exam, it's also about working in here, right? So we will make sure you have a good, clear goal ahead so that you know what you're doing. And that will be done very soon, within a week. Thank you all. Have a good night. I'll see you everyone after this free session. Take care.